All right, so those of you who have done this before know we're going to go through some papers that have got nothing to do with what the other topics are, but we thought would be interesting, provocative, and give us an opportunity to cross-pollinate each other from an intellectual point of view, at least, on some of these other things. So I'm going to get started with number one, the limited use of lights and sirens in the pre-hospital setting. And this is done by a group of people who initially, their initial study was they looked at how long it took somebody, a lights and siren ambulance, to go through a normal route, a real patient, and then they duplicated that by going in a car at the normal, following all the speed limits and stopping the stop signs and those kinds of things, and found out the difference was 2.6 minutes. And it was determined that it was unlikely that 2.6 minutes would make any difference whatsoever in the outcome of these patients, and that lights and sirens was in fact unnecessary. And in actuality, it is a major source of the accidents that occur in ambulances, where not only the people in the ambulance get injured, but the other people as well. So these guys did a similar kind of study where they looked at two communities. In one community, they had guidelines for the use of lights and sirens. In the other community, they just let them, use it as they saw fit. Exactly, and plus it's fun, ride around lights and sirens,
The indication is lunch, right?
Right.
Donuts.
It impresses girls. Yeah.
So in any case, they had about 400 ambulance runs in one community, another 400 in the other, and they were able to show that by using a protocol, which indicated when they ought to use it and when they did, they substantially decreased the use of lights and sirens, 29% in the intervention group versus 49% in the group that used it when they chose to. So I guess the message here is, and this has been a recurring message for a long time, is this should be controlled somewhat in terms of when this is used and when people are going through lights. It's interesting that in the town of Alhambra, which is in the suburbs here of Los Angeles, there was a major accident.
Just recently?
Yes, where there was a collision in an intersection of a fire engine. Was it two fire engines?
Two fire engines. They were responding to the same fire, and because of their lights and sirens, neither heard either one approaching the intersection.
And so one of these engines ran into a restaurant there, and
amputated a guy's leg. He got brought to our hospital.
Went to their hospital, and I think he wound up with two legs ultimately amputated. And there was lots of people injured, and it was a great example, perhaps, of had they been not listening, had they been able to listen, they all got these things on, they can't hear anything, that maybe this accident would not have happened. It was a really big deal here. It was about 2 months ago.
I think it raises some larger questions. So first of all, in which patient does 2.5 minutes matter?
On the way to them.
Yeah, maybe to get to a cardiac arrest, and even there, most people in big cities don't survive regardless. But yeah, maybe getting to a cardiac arrest, not to anything else. Very little.
But we know that's time sensitive, right? The Opals trial. So how soon ALS gets there matters.
But again,
in terms of arrival, but not going to the hospital.
But that's cardiac arrest. There's a very few other things where 2 minutes matters. Go ahead. Okay, so that's great. Let's get back to that in 1 second. We'll get to that in 1 second. It's a great comment. So one thing is that what you benefit from racing from the scene is very, very tiny. All you have to do is kill one extra person in an accident. And how many people have you saved? Well, in fact, there are 12,000 major injury accidents a year in the United States from ambulances. That's a lot. So if you have a few deaths, not just an amputation, but you've already ruined the whole thing. And that leads to the much bigger question. It's not just lights and sirens. What about helicopters? What about any of the things we do?
They go down like a stone.
They go down.
They do.
You kill not just the patient, but a young, healthy nurse and doctor and pilot. How many people do you have to save to make that worth it?
But Jerry, he might also have been asking about rural systems.
So that's
which is another issue.
His comment was, where are we talking about? And that's really the big dirty secret of pre-hospital medicine. I can imagine going fast, having a helicopter, doing things to really change timing if what you're talking about is a rural system where there's long, 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 long delays, their time might matter. There it might not be 2 minutes. It might be 20 minutes if you race compared to just going at normal speeds. So what happens in a city like these, small cities like in this study, large cities like Los Angeles, where it's only 5 minutes to a hospital regardless. If you go really slow, if you walk, it's 5 minutes to a hospital. So that's very different than a rural area where there might be a place for advanced paramedic providers, lights and sirens, helicopters, etc. The irony, of course, is
That's where they're not.
where do we have the money, the tax base to support big pre-hospital systems? Only in the cities. So the cities have these very complicated, crazy, invasive pre-hospital systems where there's really, it's impossible to show that they're useful. And the rural areas where maybe it would matter, we don't have them.
The worst situation is not the one, you know, you got a fire, you'd like the firemen to get there quickly. It was a tragedy, the guy ended up with amps. But the worst case in Los Angeles was like 7 years ago, where the paramedics were on scene with an asystolic arrest. We have another word for that, emeny, it's dead. Yeah. Because of pressures on the scene, they loaded up and they had no way to declare the guy dead en route because those protocols were not yet developed yet. And so then they proceeded, lights and sirens, basically in a red and white flashy hearse, to the hospital, where en route they decked a lady and killed one person in the car, seriously injured 2 others. Because the paramedic in the back was doing CPR, wasn't belted in, he had a serious injury. The driver was seriously injured. So just the injuries alone were over $2 million. Then came the lawsuit from the family of the deceased, who sued, of course, that he would have lived had they not been in that accident. Never mind the fact that they were driving really fast with a dead body. Those types of things, you know, that's when, you know, when a paramedic's on scene with ALS, they've got pretty much everything to try and get pulses back that I got. There's no reason for them to package that up and drive code 3 to the hospital. If it either works or it doesn't work. And if it doesn't work, and there's no response of return of spontaneous circulation, declare them dead in the field.
Problem is you can't carry on any intelligent discussions about EMS or fire service these days since 9/11. You can't do it because they've now become gods in their own right.
But you couldn't do it even when I used to sit on the, when I was very junior, just joined the faculty, I was assigned the worst possible job. Everybody had an administrative job. My job was EMS. So I was assigned to go to EMS, and I sat on the EMS council in Los Angeles. And the other people who sat on the council were representatives of the fire department. Conspicuously absent were paramedics. They had no place there. It was just fire chiefs. And the fire chiefs, you couldn't talk to them. Why not? Because if you took away EMS from the LA Fire Department, you took away their entire budget. That was how they made their living. So they had all these ridiculous rules that were basically designed to keep them rolling in money.
That's right.
Los
it's
Angeles
a flow of cash.
is a combined fireman-paramedic system, and so all firemen are paramedics. That's not true in many places, but it's true in LA. And in Los Angeles, 85% of their alarms are medical runs. That's why the firemen occasionally go out and light fires and do some arson, because they got into this job because they thought they were going to put out fires and catch babies thrown from windows and shit like that. And they found themselves driving around the city with drunks, and they're upset about it, so they go out and light fires every once in a while.
Yeah, I was project medical director in Ann Arbor, where 92% of the runs are medical. They called me one snowy Christmas Eve night. One of our ambulances going lights and sirens had gone through an intersection. We had ice and snow, and they're going to get an 85-year-old woman with terminal cancer, lights and sirens, and they hit 2 teenagers in a Volkswagen and kill those 2 kids. Now, if you look over the entire, and we had that whole area that we could look at the data, so when they asked me, what was your save rate for the year, I said, -1. Because we probably had somebody who we did get to in time to shock them back, but everything else was bad. What I'm saying is, if you look at the American Association of Automobile Insurers, say the most dangerous vehicle on the road is an ambulance. not just because of the ambulance, but the gawking, the this, the that.
No, the BMW following in the ambulance wake, that's my favorite.
Yeah.
Some of you have been in that car
Yeah.
who are surfing the wake of the ambulance.
Yeah.
Wow, no traffic.
Yeah.
Now, and when we get to the helicopter thing, and you always have to separate the helicopter, because there's nothing like a helicopter for search and rescue. If you want to talk search and rescue, they're hard to beat. But if you want to talk medical transport for trauma or for cardiac arrest, nothing's ever been shown they work. And they do occasionally drop from the sky like a rock.
We had one here,
Yeah,
actually.
we've had it happen multiple times.
We had
When
one
I
in
was-
our hospital, all 4 people killed.
When I was in Iceland on a Fulbright, and they do a lot of search and rescue, so I'm not arguing with the search and rescue role, but and they fly in bad weather. You know, Iceland is, you know, it's the North Atlantic, and so I finally asked them. Fortunately, not during the lecture. I said, "Well, so what do your pilots do after this? I mean, you know, after being an adrenaline junkie and plucking people out of the ocean, off sinking ships and off glaciers, what do they do after that?" And they said, "What do you mean? I mean, what's?" And the answer was, "They fly until they die." That simplifies your 401k decision making. They had never retired.
Anyway, let's move on.
So 2 is another EMS paper, and we've been sort of talking about UCA, right? There's 2 tribes of cardiac arrest. There's the INCA, that's the in-hospital cardiac arrest, and the UCA, that's the out-of-hospital cardiac arrest. And so this is a huge 15,000 database done at the University of Alabama, Birmingham, of UCA, and they did all the right stuff, the Utstein template methodology stuff, so they had all the right time intervals and atomic clock and all that stuff, so we knew what the data was. And they said, well, what's the variability across systems around the United States? And the variability of survival from VFib, VTAC arrests, of which there were 4,000, and PEA asystole arrests, of which there were 11,000, the variability, odds ratio for earlier survival went from 0.3 to 3. 10-fold differences across systems, suggesting that the variability in performance of EMS in these systems that they were looking at was huge. And we all know that from the data. When we look at Kings County in Seattle, you know, whether it's the Starbucks coffee that prevents people from dying of a cardiac arrest, or whether it's that you can't graduate from high school without demonstrating proficiency in CPR, on top of that, they have a system. What I think the real reason is that they have 30% survival is they have a system that allows paramedics to use their common sense to get on scene and go, shit, that looks dead. That looks dead. When you delete all the dead people from their work, then your survival rate looks a lot better. If you include the dead people by rushing them around the city, then your survival rate looks terrible. And that's one of the reasons why in Kings County it seems like you can't die of a cardiac arrest.
So there are
30% survival rates.
There are 2 things that I think are associated with tremendous variability. One is probably we're counting very differently.
Mm-hmm.
If you include people who are drunk as dead and you revive them, that makes it look good. If you exclude all the people who you don't start on because you have a rational system that says you don't have to start, that changes everything. I think that has to be a lot of it. Even with all the other stuff, it's inconceivable, the numbers that they post from Seattle. It's just not, it's so different than the rest of the world that it has to be a different counting system. On the other hand, there is variability related to the circumstances. And it's true that if you have to go up, what Billy said before, time to get to the patient, if it's a survivable patient, is really, really critical. You basically got to get there in 4 minutes if there's no bystander CPR, and you got to get there in 6 or 8 minutes if there is bystander CPR. Yep. It's as simple as that. And they have to be in VFib. That's, and once you exclude those people, you're not going to get any survival. So in big cities, where in New York, it's on the 23rd floor, survival approaches 0. You're in traffic where you can't get there for 10 minutes, and it's tremendously individualistic, like Los Angeles, where nobody does bystander CPR. Survival is desperately poor. If you want to have decent survival from cardiac arrest, they have to be the right person, and you have to get there quick.
But cardiac arrest is a time-sensitive problem.
It's the only one.
And we know that from OPALS and from other data that every minute you shorten dispatch to arrival, to ALS arrival, every minute you shorten that is really important. So in the OPAL study, when they went from 6 to 5 minutes, their survival rate went from 4 to 7% or something like that. And so that time matters. But once you're on scene and going to the hospital, it's hard to make a really compelling argument for that, because either they got you back or they didn't.
There are countries in the world where you can't graduate from high school without learning CPR. And, you know, it turns out it doesn't matter what you do. You don't have to pass, you know, the resuscitation course. You just have to do something. You have to press on the chest. You do that, you keep the brain alive for a couple of extra minutes. And since we're talking about minutes are critical, that's when it matters.
You know, we should have taught this differently. Most people don't like the idea of blowing in the mouth of somebody they don't know.
In New York, they won't do it even on their mother.
Right, they wouldn't. Good decision. But if you actually look at that data, particularly the Korean data and the Japanese data, where nobody breathes in anybody's mouth, it is pushing on the chest.
Yeah,
that's it.
Just CPR.
That's what we need to.
And they're starting to push that now. But
yeah.
we should have widespread bystander CPR, and then we should have rational decisions about it's too late or it isn't too late. They're in a salvageable rhythm, they're not, we got there in time or not. Still, most of them are going to die. Death is not optional. You know, we pretend that everybody's going to survive. No, most people who are being dead is a really bad prognostic indicator. So we shouldn't pretend that, you know, we can fix this, but there are a few people where the heart is too good to die, and we could do it better on them.
All right, moving on.
Number 3, diagnostic time course. This paper, number 3, looks at 41,000 people, decent-sized study, which is asking this question. If you come in the door, there are going to be those people who have ST segment elevations the moment they walk in the door. You got them. They're right. There's no question what's going to happen. What about those people who the first EKG is okay or non-diagnostic? And by the way, that's a problem with this paper. What is non-diagnostic? And then you look, and it'll be about 41 minutes or so, whatever it is, till they finally have a definitive EKG. Is there any difference in that group of people? Is the late onset ST segment elevation, are these people more likely to survive, have a smaller attack, all that sort of thing? And the answer basically from the study is it doesn't make any difference when it went up. These people have the same death rate, same this, that, and another thing. It didn't matter whether it was early on elevation of the ST segment or late elevation of the ST segment. They had about the same outcomes.
Although this paper tries to make the point that doing a second EKG in people who have non-diagnostic initial EKGs, which they were 11% of the cases, that within 90 minutes, that second EKG showed 2/3 of them showed elevations, and so the idea is
EKG is often infrequent.
And a lot of people actually have protocols where if you do one, you're going to do two.
Yeah, and that's the key point I would make. Is there are a lot of problems with this paper, and we shouldn't go into it. You know, in my mind, what is a STEMI? A STEMI is a person, I walk in the room, I don't need an EKG. I look at the patient, I go, oh my God, I'm having the big one. What was her name?
Edith.
Elizabeth.
It's the big one. You know, real STEMIs, you don't need an EKG. There's also the retrospectoscope where you go back and you look and you find out that the person actually did have an MI. So you go back and you look and say, oh yeah, look at that. See, there is a 1/4 millimeter ST elevation. That's not a STEMI. They're confusing these two. It is true that some people, first EKG is normal, they look really sick. You better repeat the EKG because they could get worse, and then you're going to make an intervention based on that. But what Rick's point is, if they need one, they need two. There are many patients who don't need any. They don't have anything, and we're just kidding ourselves when we call them, oh, there's a little ST elevation. That's not a STEMI. That's a made-up thing. So I, again, would like to go, I'm a broken record on this. We are doing tremendous disservice. We're going to have 2 talks about this by calling everybody who has a chest rule out MI.
And the other thing happens, by the way, as well.
They don't need 2 EKGs. They don't need 1 EKG. The person who you're really worried about, if the first one's normal, repeat it. That's simple.
And I was just going to say, the other thing happens as well, which is a guy comes in, and I had one yesterday on my shift, looking great. What are you there for? I got cellulitis on my legs. I fell off a ladder yesterday. And he was brought to us code STEMI. I don't know why they got an EKG. He had some cardiac history. And indeed, he had Stemi, you know, star, acute MI, but you're looking at him and he goes, are you having any chest pain? No. Are you short of breath? No. Are you diabetic or some reason why you wouldn't feel it? No. I mean, my legs hurt. And it took us about, 15 minutes of trawling in the record to find out, yeah. And he said he'd had coronary artery disease, he'd had a stent before, and sure enough, there it was. He had a known LV aneurysm with the STEMI EKG due to that.
Yeah. And some people have a bundle, or there's other reasons why you can have it. But the critical thing is that it's not the EKG that makes the diagnosis, it's the patient.
The problem is, though, that you never get to choose the EKG. All these protocols, anyone...
Oh, yeah.
The EKG's on the chart by the time you get...
Right.
Yeah, and so, right, great point. So not all bad-looking EKGs means a bad-looking patient, that's for sure. But the other thing is just, the patient comes in, they have low-risk chest pain, everything's normal. That's not the one where you're going to, oh my God, I got a second EKG and there's a STEMI on it. No, but the patient you're worried about, yes, repeat the EKG. And I wouldn't repeat it once, I'd repeat it several times.
This is why, by the way, patients should go back to the hospital they were at the last time, because when I have old EKGs, you can answer a lot of those questions.
We're going to move on to atrial fibrillation. I'm going to ask Rick to do number 5 before 4, because I think 4 is more of a summary article, so it includes what 5 is talking about.
Well, 5 is the Canadians are reporting on their experience on 927 patients with atrial fibrillation. That's a lot of patients at two hospitals, and basically they excluded all the people who had ACS, CHF, sepsis. As Jerry was talking about, they took out of this everybody who had any significant underlying diseases, and so this was basically
Lone AF.
Yeah,
the lone wolf AFib.
And they basically said, here's what we did, and a quarter of them they tried to they attempted electrical cardioversion on, and I think that this must reflect an older kind of study, because I think that in Canada the number is much higher than 23% got electrical attempting. 1 in 6 got chemical cardioversion. Rate control was in a quarter. No specific treatment in about 20%. 13% converted spontaneously in the emergency department. So it reflects a variety of things that they did, which is, I think, probably not the way it is now. And then they looked at some of their outcomes. And one of the concerns we have about messing around with atrial fibrillation in the ER is that we might cause some kind of clot to go to somebody's head. We're going to cause a stroke. Well, their number was 0.8% or something like that within 30 days had some kind of event that they would attribute to that. When they looked at who went home, 85% of the people in the ER who came in with lone atrial fibrillation went home despite whatever these attempts were to either control their rate or convert them. And that is substantially different from the U.S. In the U.S., 85% of patients with atrial fibrillation will be admitted to the hospital for some kind of some doctor to see them or do something or the other. And I think that this presents an opportunity for our Canadian brothers and sisters and I think also the Australians to say, no, guys, you got it wrong. These people don't need to come into the hospital. Most of them don't, at least, who have lone atrial fibrillation. So
number 4 is an editorial that addresses what in some areas is a very contentious issue, which is what should you do with new onset AFib. Number 5 isn't all new onset, by the way, and that's part of the problem. You can't mix and match all these things. Somebody who comes in with new onset is different than somebody who's had atrial fib for a long time. But in any case, there are people who argue with great passion about you must try to cardioavert new onset AFib, because that'll put them back in sinus rhythm. And there are other people who I think, probably not quite as passionate, but people say, no, don't try to cardioavert them. You could do harm, and there's no reason to do that. And so this has become a big contentious thing. I think number 5 surely suggests that it doesn't matter. They did all these different things, and the outcomes were great in everybody. And they sent them all home. It didn't matter whether you put them back in sinus rhythm or not. They said, wait a second, as long as they're not acutely ill, they don't have these other underlying conditions, and they're hemodynamically stable, you don't have to put them back in sinus rhythm. You can send them home as long as you have rate control and they're doing fine. So the argument of rhythm control versus rate control, in my mind, is a little bit unnecessary. Both work just fine, and it's really a matter of style.
Right, but
these
the older,
guys,
would you agree that the older person with multiple comorbidities who's got AFib, it's about rate control more?
right, so that's a different question because they excluded those. But anyway, number 4 is a really nice, I think, a really nice review of the topic. It's done in the form of the journal club that the Annals has, which was looking at a different article. We don't have to worry about that other article. They make the following points. One of them is that regardless of what you do, 2 years from now, 5 years from now, most people who are in AFib will ultimately, even if they have paroxysmal AFib that comes and goes, most of them, unless they had a good single reason for their episode of AFib, they had holiday heart syndrome, and they stopped drinking, they're going to stay out of AFib. But most people who are in AFib without a good obvious reason are going to end up being in chronic AFib. And that's true, unfortunately, whatever you do. Second, if you try really hard to keep them out of AFib, you really try rhythm control, and you're really a dog with a bone about it to try to keep them out of it, there are studies which show that trying that versus trying just to keep them minimally symptomatic by getting rate control, that there's actually the outcomes, the overall outcomes, finally, are slightly better in the rate control group. In the rate control group, there's more harm from the medicines in the rhythm control group because antiarrhythmics carry their own risks. So that in the long run, most of them are going to be in this, and most of them are going to need to be on rate control drugs just to keep their rate down. That's the best strategy. So before you get really, really, oh, you must put them back into sinus rhythm, ultimately that's not going to work, and ultimately it's not a good idea. Then the really important question is, well, what about today in this one patient? Is it better to put them back in sinus rhythm? Rick feels strongly one way. I don't feel very strongly, but I'm pretty sure it doesn't matter. And the critical thing is what he already said before, which is whatever you do, as long as you get them to where they're not hemodynamically unstable, which either means put them back in sinus rhythm or get their rate controlled, whatever you do, they can go home. And that, for me, is the most important take-home message. I don't think we should spend a lot of time arguing about, is it better to shock them, is it worse to shock them, et cetera. I don't think it matters.
But it is based on where you're from. There's no question that if you're in Canada, you're much more likely to follow the Ian Steele thing. You know, they get the procainamide, they get 1 hour, if that doesn't work, they get converted. Right, Canadians, isn't that pretty much what you're doing at this point?
Well, not everybody. A lot of Canadians.
Well, it's 100% of the Canadians that are here.
Is that true?
That's right. That's exactly right.
Okay, so let's ask, is it 100%? Is there anybody in Canada where you don't routinely do that?
Don't raise your hand. So it's 100%. Now didn't we? And we
In
have
St.
Australians.
Paul's-
We have Australians who are almost like Canadians. And what
Canadian criminals, right?
Yeah, the Canadian criminals,
That's right.
exactly.
Now, what did you guys do in Australia? You do what the
Mark,
Canadians
what do you do? No.
You just shock them.
Rate
No?
control them, and that's it.
Hey!
Well, you haven't caught up to the Canadians. What can I say? You know,
Yeah.
shock them.
He's in Melbourne. They shock him.
Shock them.
I personally, myself, have been doing rate control for many, many years, and it works just fine as long as you don't have to over-admit them, and it is much more simple, and it's much more straightforward, and it's, from an emergency standpoint, that's what we have to do.
And a bunch of the times they convert.
And many of the patients we see do have an underlying cause, and they're going to convert on their own anyway, so you're just doing extra
Well,
work.
especially with the weights in URs, they're going to be there 8 hours, 10 hours. They're going to convert anyway, no matter what the heck you do.
In our hospital, you know, one of the number one causes, we're a level
Holiday
1 alcohol
heart.
receiving. And alcohol is probably 25% of our AFib at our hospital.
And they convert spontaneously.
Well, we give them MAG, but I'm a MAGophile.
Can I ask, is there evidence around, this sort of covert putting back into sinus? So, you say, okay, we don't want to, you've been in there for maybe a week, we're worried about a stroke, we don't want to shock you, you can't do it because you're worried that you're going to get a stroke. But we'll rate control you and whoops, you've gone back into sinus rhythm. Is there any...
No. So
It's not great.
The notion that, if it's more than 24 hours or 48 hours, you read these in the literature, it's mostly made up. It is probably true that if you just immediately into the rhythm, you're not going to have a clot yet, so you're safe to go back. And there probably is some increase after you've been not really, your atrium hasn't really been functioning for a while. You build up a clot, and eventually, once you go back into sinus rhythm and it starts beating forcefully again, you could send that clot off. But the risk of it is 1% a year.
So part of the
in a
reason
couple of days, it's a teeny risk.
So part of the reason they say that it doesn't happen that much is, yes, they're in sinus rhythm, but their atrium really isn't functioning yet. So it's not like you suddenly squeeze the jello out of that atrium into the ventricle and it goes out.
No, but when
Their
you go
heart
back
doesn't
into sinus rhythm,
Yeah.
their highest risk is 2-3 days later when they're
Yeah,
now.
a little while. Takes a little while.
Although I think the thing that nobody will disagree with is 85% went home. This is not the U.S.
Yeah.
standard, and we should kind of
We
look
could
at.
do better.
Can we do better?
But remember, they have selected the people with no comorbidities.
Lone wolf AFib.
The major reason to admit somebody is because you're worried about its ACS or because they have congestive heart failure or something else. So, remember, the person who just has AFib and they're hemodynamically stable, however you got them there, they can go home.
All right, 6. 6 goes into another topic and asks the same question, can they go home? 6 is a big paper from Vanderbilt that talks about CHF. And I remember even when I was a resident, most of the people we saw who had CHF were having an acute coronary event at the time we saw them. And there wasn't this huge pool of survivors out there with their CHF being managed. Most of the CHF we saw 20 years ago was relatively new onset. And they all got admitted because they had some comorbidities and problems going on with it. That's not true anymore. Now there's a huge cohort. There's this epidemic of CHF out there, and people come into the emergency room because they were off their Lasix for a couple days, or because they had, the deep dish Sicilian pizza with anchovies and had a salt load, and so many of these people are possible quick tunes, tune up and go. And so they say, let's sort of talk about this, and they say that 80% of CHF was admitted from the ED, but they proposed that you could risk stratify them. If they were just non-compliant with their Lasix or salt indiscretion or a little bit of fluid overload and they didn't have any new EKG changes or some new acute reason for cardiac decompensation, then you should do a quick trial. And they said that the low-risk ones, you could check the response to treatment with diuretics, topical nitro, and maybe a little brief trial of BiPAP. And if they do well, 30% they suggest could go to direct discharge. For the intermediate group, you might even consider an OBS unit for them, where you take a little more time to tune them up, but don't admit them. And then they say anyone who fails this approach would be admitted. And then, of course, the people who have some acute chest pain or acute decompensated medical condition associated with their CHF, those would be admitted as well. And they say that in the face of this huge CHF epidemic, that a common sense approach that identifies, just as we talked about with atrial fibrillation, a low-risk cohort where a little bit of tune-up, a little bit of offloading of some fluids, and they could go.
I don't think this is a new concept. It's always been true, but I think we have to be a little careful about it. There are basically 2 reasons why somebody's in failure. One is because their pump function is failing. And those are the people who usually have ischemic myocardium, and they can't do it. And those people need nitrates and maybe some BiPAP, but basically nitrates is the treatment. This article is written by cardiologists who for years have been mistakenly claiming that the treatment of acute CHF is diuretics, when the cardiology literature is full of stuff saying that's not the treatment. It doesn't work quickly. So yes, there is a subset where it's just indiscretion. I think they overrate that subset. I think in my world, most people who are in acute pulmonary edema, which is the one I worry about, they're having pump dysfunction. And that's a very different thing. And they do need to be in the hospital. But yes, the person who, the cause of their CHF is Thanksgiving. They overindulged, they didn't take their medicine. Yes, many of them can just be tuned up.
And we see a lot, again, I work at a county hospital where people can't get access to care, so they have medical noncompliance just because they can't really get into a doctor and get meds, and some of them I think are relatively quickly tunable. Now, if you want to talk about the whole pie chart, though, of CHF, one of the things that I think is kind of important to remember is that 70% of CHF has some component of fluid overload, either whether it's pump dysfunction, redistribution, whatnot. But that still means that 30% doesn't. And if you take that 30% that's not fluid overloaded and treat them with Lasix, they get worse. And among that group, the one disease entity that I would point to a lot, so if you look at, for example, the big Canadian trial of CHF and looked at why CHF got worse, among patients who can get their meds and do get follow-up and have family practitioners, like in Canada, one of the reasons that they go into CHF is they get pneumonia, and there's a very bad interaction, and they're febrile, and they're coughing, and they're not taking good POs. And so in the pneumonia CHF subset, you got to worry that some of those are actually not fluid overloaded, that they're either euvolemic or hypovolemic failure, and they're going to get worse with Lasix. Giving a euvolemic or hypovolemic failure patient Lasix will make them worse.
And in the ischemic patient, who also is not fluid overloaded, they're
Acute
relatively
ischemic, right.
unable to handle it. Lasix is worse for another reason, which is that it causes hypokalemia, and the worst thing you can do to somebody who's acutely ischemic is give them a fatal arrhythmia by making them hypokalemic.
Yeah, and also depletes you of magnesium.
Yeah. So I think the whole cardiology literature, the review literature about CHF is wacky because the research literature makes it clear that what we're saying, but the review literature is all about diuretics, which is what this paper is about. Yes, there is a subset, the person who's just a little out of tune, but our job is to look for the other patients.
Yeah, I think the other job in the emergency department is make sure that there is some reasonable follow-up here. You realize that if someone comes in with congestive heart failure, they've got twice the chance of dying this year as somebody who's got stage 2 lung cancer. Exactly. So I think that the follow-up is more important than anything else, and that's where we're getting a little better, at least at my center.
And
we're taking it seriously.
Recurrent acute pulmonary edema has a higher mortality than acute MI.
Right.
In the next 2
Although,
years.
Medicare here in the States is really pushing on this diagnosis. This is the most expensive diagnosis in Medicare, so they're trying to, limit 30-day readmissions to see what you can do to prevent that, making sure the follow-up and then making the phone calls and checking the weight and all of these other things.
One way to avoid a 30-day readmission is not to admit them.
And that's partly what these guys are talking about here.
Yeah.
CHF is sort of an example of our healthcare system not really thinking very, very clearly because it is a fatal disease. These are people are really, really sick. It's a disease where acutely we are fabulous at treating them. Nitrates work phenomenally well unless they're hypotensive, in which case they're going to die. They have cardiogenic shock, they're going to die. But somebody who's not in cardiogenic shock, we have a great, great treatment for them. But it's a very limited treatment. We can call it a save all you want, but they're going to be back dead in not too long. Yep. And so we spend huge amounts of money for basically a losing proposition.
Gregory.
All right. Article 7 has to do with capillary refill. How many of you learned capillary refill in medical school?
Oh, yeah.
We all did. We went by, we pushed, they say, nah, they're all right. It's okay. This is a study that comes from Egypt, and what they did, I don't know how they got permission for this study.
It's from Egypt.
And what they do is they took the cardiac output in children who are undergoing cardiac catheterization.
They're clearly normal kids. I cath all my kids.
Don't you do that in everybody?
Yeah.
So they actually looked at that, and unfortunately the correlation between capillary refill and the actual pressures is horrible. You might as well have flipped a coin. So what it basically says is capillary refill as a judgment mechanism as to whether your patient is doing well or not probably isn't good enough.
In sick kids with frogs with 3-chambered hearts, endocardial cushion defects, and all the other reasons why these kids were going to cath.
Yeah, so right. Exactly.
To pretend that even if this was a good study, that you could generalize it to normal kids who aren't going to cath.
But I think that
some of these kids do that normal cath.
But I think it's true, and we should be honest that
capillary refill.
If it's completely off, it takes a month to stop blanching. I don't think you need capillary refill to figure out that that's a sick person. And the other ones, you're making it up. Oh yeah, no, it was 2 seconds. It was a second and a half. Right. At what point did you stop counting? The ones where we need help, where I can't really tell exactly this is not going to help you. You're making it up. And the ones where it is obvious, you don't need it. They are clearly sick. And I'm pretty sure if it's true of kids who have really bad cardiac output, it's probably true of the ones where it's marginal too. Number 8 is something I really like. I've heard people on the panel, other panels criticize this study, and it's actually something I think is great. It's an ACEP policy which basically says, what should we do when a patient comes in, they look fine, but they were sent in from clinic because their blood pressure was high. Oh my God, it's 220, it's 240, whatever it is. And this policy looks very different than the classic policy that you read. The classic policy says there are 93 studies, most of them we rejected because they're terrible. Of the 5 studies we actually looked at, they were heterogeneous, poor quality, disagreed with each other, and here's the answer down to 3 decimal points of what you must do. Sort of crazy. This says the opposite. It says, you know what? We can't really tell you what to do because the evidence is lousy. And I like that. That's what most guidelines should say. You know what? There isn't really good evidence. Now, in the absence of really good evidence, let's look at circumstantial evidence and see what it best suggests. And that's what they did here. And what they say is the circumstantial evidence suggests that you don't need to lower blood pressure acutely. There's no reason to. Most people will lower spontaneously on their own and get better. And tomorrow, it doesn't matter what you did. By 24 hours afterwards, if in the few studies that have been done, the people who got aggressive therapy, 1 dose or nothing, their blood pressure was all the same 24 hours later.
Unfortunately, the reason their blood pressure was high was because they were worried they were going blind in one eye from their diabetic retinopathy, and now that won't get fixed, so they'll stay anxious about their diabetic retinopathy because every time they go to the eye clinic, they get sent back to the emergency room because their blood pressure's high.
But the other thing,
until you can convince the ophthalmologist to see someone with a high blood pressure, they'll keep refusing to cure them and keep sending them to the emergency room.
The other thing that this policy said is, not only is there no reason to think that we should be aggressive about lowering blood pressure, but if you are aggressive about it, well, there's pretty good evidence that maybe 1 out of 100 or 2 out of 100 you will cause a stroke or a heart attack. And that's a lot worse than any conceivable benefit of doing this. So I think they did everything right here. They acknowledged that there are no good studies, there's no prospective studies comparing one approach versus the other, but there's a lot of circumstantial evidence to make the 2 points. No reason to do it. You don't need to do it. You don't need to get crazy about it. There is no such thing as hypertensive urgency. And on the other hand, when you do it, you will hurt. Every once in a while, you'll really hurt somebody. So don't do it. They also say one other thing, which I think is probably true, which is you get those patients, don't start doing a big workup for electrolytes and magnesium and looking at their renal function. You don't need to do any of that. They need follow-up, period, done.
My favorite is when they're at dialysis. Right. So they're at the place with the cure. And then they send them to me where I don't have the cure because their blood pressure's too high or they're short of breath. And I'm like, yeah, just once I want to make a preemptive attack. I want to see someone with high blood pressure who's got like an eye problem, and I want to send them to the eye clinic and say, I can't lower their blood pressure until you fix their eye problem. I just want to see what they do with that, because they're constantly sending shit to me that they can't do until I fix the blood pressure. I just want to try going the other way just for shits and giggles.
Have you had that happen, by the way? I mean, I've had that happen where dialysis constantly sends them. It's like, what are they thinking?
Yep. Or my other favorite is the sugar's 350. We can't see him in eye clinic today. What, you were worried that honey was going to drip out of his eyeball onto the slit lamp? Why can't you see him?
What did eye clinic do to you recently? You know, they're picking on eye clinic.
Yeah, I'm picking on the eye guys. It's like skeet shooting at a slow-moving blimp. They're an easy target.
Yeah. By the way, there is a thing we do in emergency medicine all the time, though, is we take the blood pressure. They're in there for something. I don't know, their ankle, their knee, whatever it is, and it's elevated. What are you going to do with it? Well, we have several good papers in the database that say, you know, maybe half the time it is that pain. The other half the time, they may actually have elevated blood pressure, but none of it has to be treated today. Here's my medical legal advice to you. You circle it, you tell them what it is, have it rechecked at some other time in the near future, but don't jump in with medications right away.
One of the hallmarks of emergency medicine is that we do a directed history and physical. You come in with ankle pain, we look at your ankle, but that's what we should be doing. Unfortunately, we violate that in many ways. One of the ways we violate that is vital signs. We do vital signs in everybody. That's not a directed exam. Why are we doing that? Okay, that's Fortunately, we can mostly deal with it just doing what Greg says. Now, with the regulators, we're violating it in every way. We do a 12-part review of system when you have an ankle sprain. Well, guess what that's going to do? Nothing good, lots of potential harm. And we don't just do that. Now for billing, we do a big exam, and this is crazy. This is the opposite of what we should be doing.
Yeah.
But I don't know how to fix it.
How many people here have a box that says all of their systems reviewed and found to be normal or negative? Yeah, you're
That's
a
called lying.
Yeah, you're just lying.
See, the Canadians and the Australians have no idea what we're talking about. But basically,
Changing emergency medicine to
As soon as they want to tell me their review of systems, that's when I intubate them.
Yeah.
Then it's review of systems is unavailable.
Yeah.
we have mandatory charting requirements here in the States regarding Medicare patients.
We're going to talk a lot about screening and the concept of looking where you shouldn't be looking, where you have no reason to worry, and how that causes enormous harm, medical harm, not just cost, medical harm. And when we change emergency medicine into screening for everything, we're going to do lots of harm.
It's terrible, and everybody comes along and wants you to do something. I had to go and fight with the people at the feds when I was president of the college about this 1, 2, 3, 4, 5 level. And the problem with the 1, 2, 3, 4, 5 level is you get paid more money as you move up that chain. So what did people do? They wrote down a lot of crap, and I just told the guy at CMS then, I said, look, if you want to fight about the money, let's do that. But don't make America's largest liars club. And if you look at all of these templated things, the template comes up with crap that you never did. And it's just now the way we're doing business.
It's really bad. Hey,
Well, Jerry, you liked the clinical policy abstract number 8 and how they did it and how straightforward they were, and they acknowledged that they didn't have information. So how do you feel about the TPA policy? Same organization, yeah.
we don't have enough time in the week.
All right.
Yeah.
Anyway, number 9 is a quickie. It's
enough
it's
Zofran.
just about how Canadian parents were surveyed regarding fever, and this is the same old. But even Canadians don't have it, quite right about this thing. There is still, even in Canada, they have persistent fever phobia. The part I liked the best was 28% of the people who answered the survey check their kids' temperature every 30 to 60 minutes or more frequently. How could you possibly do it more frequently than 30 to 60? They just leave the thermometer in permanently. Just leave it in there.
And then they bring you the sheet, which has listed the temperature at every minute for the day.
Periodically, they remove it from the kid's butt and then put it back in,
My favorite is wake the child up every half hour to see if he has a fever.
Right.
Or see if they're irritable in the case of head trauma.
You
wake me up every 30 minutes, I'm going to be irritable.
Favorite. But, what's the bottom line in all this? Fever is not dangerous. We should stop worrying about fever. The whole notion of this is the classic disease-oriented marker that has nothing to do with what we're interested in. The reason to treat a fever is because the kid is sick, because the kid feels lousy, and you'll make him feel better. The goal should be he's feeling better. It has nothing to do with the temperature. Yet this documents that we have created this monster where most people believe that fever is dangerous, and you got to spend a lot of time doing it. That's why the notion of waking a child up to see if he has a fever is crazy. What you want to know is he well enough to fall asleep? Wake him up so that you could find out if he's sleeping or not? I mean,
but they also pointed out that what half the patients said that they'd like an explanation of why their kid has the fever, and a quarter of them wanted to have advice regarding
why do you
the
think
management
your kid
of
has a fever?
They get a virus.
They have a virus. Does it matter
That's
what
just
the temperature
standard
is?
answer, virus.
It's a virus.
It's a virus.
It's a virus.
It's a virus.
Virus.
Don't worry, I think it's Marburg, or it could be MERS-CoA.
But it's a virus.
So if they
quarantine your
have-
child, it'll be fine.
If they have a
Ebola.
virus, just start IV Tamiflu and everybody's okay.
So 10 is a UK paper that it's not worth talking about except to make some fun of it. They said, well, maybe giving antipyretics for fever makes the disease worse, because the reason you mount a fever, in part, is to mobilize your immune system, and because things like RSV and coronavirus, all the booger-causing viruses, the reason they live in the booger-causing places is because those are cool places with evaporative cooling in your upper respiratory tract. They like it cool, they replicate better with cool temperatures, and the reason you mount a fever is to shut down their replication. So this paper asks, well, maybe treating them with antipyretics prolongs the illness. So these UK authors found 6 studies, and here's where it gets really funny, 3 of which included malaria patients. All right, well, I don't really want to talk about malaria and fever in this. That seems sort of crazy. But 3 included varicella and URI, and they found no evidence that the disease lasted longer when you made the kid comfortable by bringing the temperature down.
So you don't need to worry about fever, and you don't need to treat it. It's different if it's 108, and it's different if it's hyperthermia, which is not that my hypothalamus wants to reset my temperature set point a little higher. That's a fever. My hypothalamus has got an indication from some bug that I really would rather live 2 degrees higher. That's very different. That's not dangerous. Hyperthermia, which is environmental, I want to be at 98.6, but I'm being overwhelmed and I can't get rid of it. There, very high temperatures matter. But that's a very, very different thing. So on the one hand, don't worry about a fever. It's not a big deal. On the other hand, the notion of, oh my God, don't treat it because it'll harm you because you need the high temperature, that's also silly.
And McGill did a similar paper in Canada a couple years back that found that there was no evidence of disease prolongation with treating fever either, with traditional URIs.
The next couple are about UTIs in kids in fever. And I'm going to just say that number 11 is so important that Greg's going to do in a second. Let me just mention that number 12 should go first. Number 11 summarizes the whole area, and it includes things like number 12. There are many sources of information that this searching for UTIs in a kid with a fever, because God forbid you'll miss the occult UTI and they'll end up with renal failure. There are many, many sources of evidence that that's not true. And I'm not going to even talk about number 12. It's one of the sources of evidence because number 11 covers it really beautifully.
Well, as Jerry points out, if this was such a bad problem in the United States, wouldn't the streets be littered with children with kidney disease?
And Urich children.
With us, we would all have.
We'd all be dead.
If you actually look at the claims made about occult UTI, that it's at 5% of the kids with a fever, and you think about an average kid between 0 and 2 has 7 febrile episodes a year, we should all have renal disease because we didn't get antibiotics for every time we had a fever. So
paper 11 actually comes out of the Annals of Emergency Medicine, 2013, a recent paper. And it basically asks this: does the evidence support aggressively pursuing the diagnosis?
Meaning cathing kids and things like that.
Kids, that sort of thing. Do we need to do this on kids who otherwise look pretty well in front of us? We're not talking about the child who obviously looks sick and ill laying there. We're talking about that kid who's asking for the second popsicle, and you know, maybe they got a few white cells, maybe they don't. And basically the bottom line is, even if you look at the guidelines of the pediatricians, bottom line is there's not a lot to suggest that we should be cathing every kid who comes in.
Oh, wait, I think that's way unfair. It's not that there's not a lot to suggest. There's overwhelming reason to believe it's not true.
Yeah.
If you look at kids who have UTIs, they don't end up with problems with definite UTIs. If you don't do anything, nothing bad happens. If you look at the renal scarring, that is the big bugaboo that these pediatricians talk about, it goes away, and it has no correlate. If you look at people who end up with renal disease, and you go back and you look for, oh, where was that occult UTI? It's never a UTI that caused it. It's never 7 UTIs that caused it, unless they had clear-cut anatomical abnormalities. However you slice, if you look at renal dialysis units, none of these came from this. And this is not trivial. So we're talking about the little kid you have with a fever. Those of you who were practicing 25 years ago, what we did was we looked at them and said, is he normal? And if he wasn't normal, then you did a whole big workup. And if he was normal, you said it's...
But the AAP is still so the AAP, one of my problems with the AAP is they won't read literature that's not by pediatricians. So for example, we have a whole body of literature that says that if you have blunt abdominal trauma, the indication for working up your GU tract is gross hematuria. But the AAP won't read that, so they're still recommending you work up microscopic hematuria. There's no reason to suspect that kids are not just small adults, and the AAP continues to do harm. For years, the AAP wouldn't read the adult literature that says that people feel really uncomfortable when they're barfing and shitting their brains out, and giving them some symptom control would make them feel better. So they said you were an evil doctor if you did this for kids. No. And finally, in this realm, the AAP is still recommending a full workup for a first-time UTI, including voiding urethograms. No, you got a recurrent UTI, there's some reason to think you got posterior urethral valves, or you got duplication of the ureters, or some GU issue. You got a recurrent problem, I'm all for the workup. But to not have read any of this other evidence that Jerry's talking about and still be recommending the AAP, but still recommending aggressive workup of a first-time UTI with imaging, they're off their gourd.
But I think it's a bigger problem. It's not the first time UTI. I think it's the created UTI. So as I was saying, 15 years ago, we changed from look at the kid and make a clinical diagnosis to you have to do a workup for occult bacteremia. And that was a completely made-up disease. And I think there was lots of reason to believe that that was a crazy notion, but we did it for 15 years, or many people did it. And then finally we had all the vaccines, and it's clear that if you do blood cultures, almost all the positives are false positives. So now they've changed that. No, you don't have to do that anymore. They created a new disease. Instead of occult bacteremia, it's occult pyelonephritis. And what that means is you have a little kid with a fever, and you have to go searching for urinary tract infection. Unfortunately, that doesn't mean catching some urine. It means an invasive procedure, because catching the urine, there's all sorts of problems. So you have to now catheterize the kid or do a suprapubic tap. And now, guess what? 5% of them turn out to be positive. And these guys are tearing their hair. Oh my God, you can't miss them. Turns out that not only all the evidence I already told you about, but if you do background noise, kids who go to the OR for some entirely different reason, 3 to 5% of them have a positive urine culture. Yeah. That is to say, they have asymptomatic bacteriuria. It's not pyelonephritis. So I believe, and I've been saying this for years now, that we are hurting children doing these tests that we don't need to. You should only go looking for urinary tract infection if you have a reason to believe they have it, not because they have a fever. They have a fever, it's called a virus. The incidence of positive urine is just as high in kids with bronchiolitis as with nothing. It's just as high in kids who have an obvious upper respiratory infection as in kids who have no reason to have anything. We are creating a disease with harm to our patients, and I don't think we should do it.
How do you feel about it?
So,
number 11, wishy-washy.
Number 11 is a wonderful review of all of this. If those of you who want to say, no, I'm not hurting my kids, this is the one to look at.
Well, I would ask, do any of you work at a pediatric emergency department?
Oh, you have to do it there.
Because, and do they cath kids like crazy there?
Oh, yeah.
Yeah.
If you don't, you're like a renegade evil bastard.
Because, I know the answer, because every time we ask that question, they are the believers that they have got the right way here, and the rest of us are
But if
nuts.
you actually look at, there's also studies which look at what happens in the real world if it's outside of pediatric EDs, and there, most people with a fever, they call their family doctor or their family pediatrician. And when they survey what the family doctor and the family pediatrician does, they never do any of this stuff. They do nothing.
I'm waiting for the statement of concern from my last peds shift because I didn't do it on a couple of them. I'll get written up for it.
Well, they probably say it's a recurrence of that otitis media. I'll call in some amoxicillin for you. That's really what they do, which is unfortunate. But the fact of the matter is that
be nice.
We are supposed to emulate what happens.
Be nice so I can be the mad one.
We're supposed to emulate what happens at these places that know better than, that's their job. They specialize in kids kind of thing. And every one of them does this, and it takes a lot to try to get the community physicians not to emulate them as well.
And really, what you're talking about, and what I was saying, when the peds people won't read the adult literature that might pertain to them, this is all about this ivory tower, specialty-related siloing. I live in that world, and trust me, they're siloed up. They won't look outside their silo.
So, do you have any thoughts about it, Doctor? the emergency medicine?
No, they're pediatricians who did a fellowship.
For those of you who haven't worked with them, I'll just tell you that someone does EM and then does PEDS-ER is very different from someone who does PEDS and then does PEDS-ER. Those are totally different animals.
All right, so I think we made the case. Should we move on?
Yeah.
Show.
What is it?
Blood culture contamination.
You know, the way to not get your blood culture contaminated is to stop doing it.
Yes.
That's the best
Here,
way.
here.
They suggest that contamination rates are high, as Jerry acknowledged, and that most of them are false positives. And if you are sincere about trying to get a blood culture that is not contaminated, that these people show that they were able to teach people how to do it more properly. And one of the ways I think was most important of the things that they did here was to have the person who drew the culture put their initials on the specimen, so that when you find out that this person is the recurring cause of abnormal or false positive cultures, that you go and you beat them with a rubber hose.
You have to find the fomite. We have found the fomite, and it is you.
And you correct the problem.
So it suggests that if you can really dramatically decrease contamination rates, that it has to do with not being careful, not just doing it carefully and cleanly. And that's why identifying the person makes them be much more careful, and they do it. I agree with Rick that the vast majority of blood culture should not be done, and that's not the issue. What it does raise for me that's interesting is that it doesn't matter how much we know this and how much we preach it. Nothing changes in most of our places. This is going to change, though, in all of our places, because the feds now have told us that if you have a false positive culture, they're going to penalize you economically. So once that happens, we don't have to preach this. We will all do it. We will all be really careful and have good blood cultures. You know, it should be a no-brainer. But the more important thing is don't do these blood cultures in the vast majority of cases.
All right, 14, about imaging choices in peds. It's a big review of 10,000 kids from the years 1997 to 2009. And they just looked at what was done and the rule out appy cases. And this is sort of an embarrassment kind of paper. I don't know if they intended to be a doctor bash, but it should be. 70% of the kids were imaged with CT alone. Ouch. You know, the rest of the world has stopped doing this a long time ago. Ultrasound ought to be the first. 22% were ultrasound alone, and 8% got both. And I can understand there's some times when you need to get both, which is when the tech says they can't see it or it was poorly. And sometimes I feel like the techs are in the cahoots of referring to the radiologist. The techs really got to want to help you. Otherwise, you order the ultrasound, they punish you for that by telling you every time you order it that there was some fart in the way. So they couldn't see the, appy not visualized, appendix not visualized because intervening gas. But in any event, this is, I think, fairly condemning of what the practices were during those years. More condemning of those practices was the following: the predictors of CT alone. What would make you get a CT alone, other than the fact that you hadn't read any papers for some years? The predictors of that were older age. So maybe they were entertaining some other diagnoses. All right, fine. Private insurance. Someone was going to pay for the CT. And admission on a weekend. Somebody didn't want to come in to get to see the kid and requested you got a CT, meaning the surgeon. Man with knife, no come till CT done.
Well, that's a problem anyway. But so the bottom line, of course, is we've talked about this a lot, is that in kids we're trying to avoid radiation, and so and ultrasound is in many, especially thin young person, it's an adequate test. It's not quite as good as a CT, but for the many patients, it will give you the answer and you can be done. If you have realize the same is true with CT, but a little less so. But for any test that you do, you're sure the kid has an appy and the test is negative, understand that there are false negatives. You're sure the kid is fine, don't do the test in the first place.
The surgeons, though, will use this paper, even this paper that we're all talking about here is very pro-ultrasound. The surgeons will read this paper and say, no, this paper says get the CT, because the highest negative appy rate was in the ultrasound alone group, and the surgeons are graded on the number of times they go to the OR for a non-therapeutic lab. They are not punished based on perf rate, because perf rate is obviously much more complicated. How long did they wait to come in? what else was going on. And there have been other papers that talked about this QA process around appendicitis that said that if we just changed the way we rated the QA process, that every perf was perceived as 10 times as important, because it really is, as every negative therapeutic lap, we could change surgical behavior. But we haven't done that. In fact, we ignore the perf rate and focus on the non-therapeutic lap rate. Surgeons are graded on it. The QA process measures it and tracks it. And so a surgeon will read this paper and say, highest non-therapeutic lap rate, ultrasound alone. Homie, don't play that.
Yeah, by the way, we say this as if we're condemning surgeons as a group. Not true.
No, it's their
QA
QA process.
I deal with a lot of ped surgeons who, and particularly the older guys, our age on this panel, they'll come down, feel an 8-year-old boy's belly, and take him to surgery and just take it out. When you think about it, how many diseases in a young male are there that cause rebound guarding, positive leg signs, and the old guys will all take them out based on that? When you think about it, it's an operation that takes them about 15, 20 minutes. They're very good at it. And the downside of taking out a normal appendix is so small.
Especially if you were to talk about laparoscopic surgery. I mean, but unfortunately, what's your experience? You have the same experience that there are a few of the older surgeons who do it, but the young ones never do it?
The young ones won't do it. That's my experience.
Well, according to this study, 92% of the patients had either ultrasound or CT. And so I got to think this is the ultrasound. This is the new CBC of the young surgeons, as well as the imaging show. And I would ask you, though, how many of you largely have transitioned to ultrasound first in the evaluation?
We finally have.
Okay, so 2 Canadians. Okay, where's the Australians? Come on, let's see the Australian hands over there, kind of thing.
Ultrasound?
Because, you know, in this country, we often hear, well, this is a technician-dependent test. We don't really do it very often, kind of thing. We really don't feel very confident in it. And so that just kind of, just do the CT.
So we did a paper recently, I don't remember where it came from, where they actually had a rule that if you're going to do a CT, you must also do the ultrasound. They didn't charge the patients. They said, you know what, we'll never get good at this unless we do it. So, okay, you're not good at it, that's fine, but from now on, every time we do a CT to look for appendicitis, we also do an ultrasound, so we'll learn, and then we'll get good.
Well, I felt that way for a while. This is not 6 months ago. I had a kid who had a little bit of an atypical presentation, but it sounded like an appy to me. I got an ultrasound, it was positive appy. The surgeons came down and said, well, it's a little bit of atypical. I see that the ultrasound's positive, but humor us, get the CT scan. So
Billy, they're all atypical.
So I get the CT scan, and it's positive. So I call the surgeons back. I said, listen, I told you it was an appy clinically. The ultrasound says it's an appy. The CT says it's an appy. Can I get you an MRI? Because I don't want to rush to surgery on this. I'm sure we can delay long enough for him to perf. And there was a pause on the other end of the line.
As they were writing you up for the 35th time.
Yeah. I have to say that I was sort of shocked a moment ago where Greg said, it's not that we're ragging on surgeons, and Billy said, no. It's like, excuse me?
We are.
Billy?
We are.
Billy, you're not ragging on surgeons? Come on. Yeah. Let's be
honest.
No,
I was saying no to Greg. Yes, my comment was no, we are ragging on surgeons.
Yeah. Anyway, one other point that Greg made in passing that I think we should really stress, which is that the diagnosis of appendicitis is very difficult in women.
Yeah.
We often get it wrong. Now, we usually write that it's something that needs surgery or not, but often we get confused, the pelvis and appendicitis. On the other hand, young men, it's an incredibly easy diagnosis. And when you look at the actual influence of CT scans on outcomes,
it's been done, huge studies.
Huge studies have shown that in males it has no effect. It just adds cost and time and effort, and maybe a little bit of perforation.
Actually,
in women, it's really,
in the huge Oregon study, it increased the perf rate. That's all CT did. Advanced imaging increased the perf rate because it was delayed. And that was back in the days when you had to give them oral prep and all that.
We cannot take them to the OR, so we can talk all we want. The surgeons would have to agree, and you need to have a surgeon who's willing to go to the OR in a young male without any imaging, which is really what we should be doing. But we should be pushing that at least.
majority of the really good literature on ultrasound is not from the United States,
It's all
obviously.
Europe.
It's from the Europeans. And some of the best papers over there where they've done large series basically are showing that ultrasound sensitivity for appendicitis is in the neighborhood of 90%. Those are the best. CT is 95%. So we're talking a relatively small difference when you really got it down, when they do it routinely and they feel comfortable at it. But they've done it. And I think the issue is we can do it, but we have to basically incentivize people to be willing to make this transition. And it's so easy for us to order CT that there's no incentive to change this.
Number 15.
It just has to do with radiation exposure, same thing in appendicitis. Bottom line is I've seen a disaster with this. Saw a young child, obvious appendicitis. They insist on the CT scan. We get it. It's not quite positive enough. So what they say is watch him overnight. The resident came in, the resident came in the morning and ordered a second CT scan. So now this child has had 2 doses, 450 times the radiation of a chest x-ray within about 12 hours on a kid that should have just gone to the operating room. And I think it's more than just the cost, money-wise, it's immoral. There are 3 grandparents sitting on this panel. You wouldn't do that to one of my grandchildren, I'll tell you that right now.
I'm sure many people breathed a sigh of relief that it wasn't 4. Yes, no, I don't have children. I don't have children.
Well,
For those of you who are worried and thinking of calling DCFS, don't worry, I didn't have any.
No.
That he knows of.
Not that you know of.
Not that we know
Not
of.
that you know of.
Yes.
Well, actually, I didn't let it happen, but when the surgeons take over, they think they're in charge. And it did go through, they filled it out. Believe me, it was a disaster as far as when it worked its way through committee, because this is just unacceptable on somebody with rebound guarding ready to go to the operating room. I don't understand it.
Number 16, I wouldn't really, we can sort of pass over it. The data in this is very poor, and I don't think it actually proves what it says. But there is a principle, I'll just sort of mention it to you. I never got to talk about spectrum bias today in the first talk about reading a paper. This claims to show that people, that when you're looking for API, a CT scan doesn't matter whether there are 6 hours of pain, 3 hours of pain, 9 hours of pain. But in the group with ultrasound, the longer the pain was, the better the ultrasound performed. Now, the data isn't very good, so I don't know that we can believe that. But I do think it does raise a sort of principle, which is that we think tests have a certain ability to tell the truth. And the fact is that their ability to tell the truth varies according to how sick you are. So if you have a subarachnoid hemorrhage where all you have is a little headache, and there's only 3 cells, red cells in your brain, the CT is going to miss that routinely. Whereas if it's big enough to make you fall down on the ground, you have a lot of blood in your brain, and guess what? The CT never misses that. And that's called spectrum bias. The severity of the disease affects the outcome. The same is true here. The moment that the little fecalith gets in the appendiceal duct, and you start to have a little bit of discomfort, that's when we can't really tell whether or not the person has appendicitis. It's too early. Guess what? The test can't tell either. The white count is still normal, the CT scan is still normal, the ultrasound. When you get full-blown stuff and the disease is really, really bad, that's when all the tests are normal. Guess what? That's when we don't need tests. When the patient's clinically obvious, it's an unfortunate truth of almost all laboratory tests and imaging that they're really good when you don't need them. When the person's clinically obvious, you don't need the test. When the person's really got an MI, you don't need the EKG. When the person is really, I don't know, could be, is marginal, that's the spectrum of disease where the test also doesn't know. We've shown this very, very clearly for BNPs. BNP is a useless test because it's always right when you're sure that the patient has the disease or is normal, and it never knows when you don't know. So that's the only thing I would take from
No, but
this
Jerry,
paper.
if the white count's 21, it's too high for appendicitis.
Absolutely.
Right.
I love that one. How many of you have been told the white count's too high for it to be appendicitis?
Well,
that would I have a hard time
I
wrapping
haven't-
my head around.
You know, they don't ask for white counts anymore. Now they ask for CT scans. But in the old days, when they would ask for white counts, I had a really easy answer. I would just say it's 12. because I know 12 means, if I want them to go to the OR, I'd say it's 12 or 14, because that's the right
14's
answer.
better.
And I know that surgeons actually don't read, so they won't know that I never actually sent a white count.
And if they call you on it and you go, oh, I was talking about bed 11, sorry, I crossed them up.
I always love it when one of the residents will see 3 to 5 white cells in the urine and say, oh, they must have cystitis. And I say, they've got pain in their right lower quadrant. Do they have hemicystitis? How did that happen? But they don't want to take these people to the OR.
17 is a statement by the American Academy of Emergency Medicine, which in the States, you know, is one of the other organizations that have 4,000 or 5,000 represented doctors. And they basically came up and said, let's come up with a recommendation for the use of contrast in CTs, because we've been wrestling with this. This is about IV and oral. And they did a literature search, and they basically concluded the diagnostic accuracy of contrast enhanced is 94 to 97%. The literature says that unenhanced is between 94 and 97%, which is the same. Sensitivity between 90 and 98%, and specificity 95 to 98. And that's honestly as good as you're going to get. And you don't have to give the patient IV contrast and the risk of that, and you don't have to do the oral and the time involved in that.
Took forever for us to get our radiologists to yield on the no IV and oral contrast. We had to bludgeon them.
They have
for
a policy.
months.
They have a one-paragraph policy at USC that basically says no oral contrast unless you suspect a hole in the bowel. And that's
Crohn's disease, some fistulous tract,
So
abscess.
Or vascular. So vascular, that's important to know.
Yeah.
You're looking for vascular disease, you're looking for bowel disease, then you need contrast. Otherwise, you don't.
You all differentiate skinny children with fat out like appendix.
You know, some people, I think some people try to do that, but I don't know that that's very consistent. I still think that that's the ultrasound first is the way to go. And if it's positive on the ultrasound, skinny or fat, then it's positive. Specificity is excellent once in these tests. It's just the sensitivity is an issue. In the CT, the sensitivity really is not an issue. The sensitivity is approaching. In fact, we did a half-hour talk on all of this literature, and there was a 26-study meta-analysis which actually concluded that they were similar. But the reality was, when you looked at the number, unenhanced was better than enhanced.
My favorite is keep them NPO for 12 hours, but give them 700 liters of contrast. Excuse me? How does that work?
There's this 3-hour prep.
So
they're MPO, and you're making them, you're forced jugs of contrast down.
If your radiologists are still basically forcing you to use contrast, get this paper. Look at the studies that it is cited in this paper.
Well, we have a whole bunch, and really, if you go through the database,
better than this paper.
You can show many. There's really good stuff showing that this is crazy. You don't need contrast.
18 talks about the digital rectal exam and how much can you ascertain from it, and they had a bunch of things, and it's like 16 studies, 2 with undifferentiated abdominal pain. How often did the rectal find it for you? No, zilch. 5 studies rule out API. Did the rectal help? I mean, if you think you can reach someone's appendix through their rectum, you're crueler than me. 6 studies regarding sphincter tone. Yes, there was some correlation with sphincter manometry. I don't know who's putting pressure valves up people's butts, but they did. And then 3 studies on stool samples that pointed out that, at last I checked, the stool is full of bacteria, and so there'll be lots of false positives if you're looking for bacteria in the stool. And they conclude that that it's limited utility. But as an attending staff who's fairly frequently asking my residents to be compulsive and complete, I do have to point out that they didn't ask about prostatitis. They didn't ask about GI bleeding and erosive gastritis. They didn't ask about anal pain and anal complaints or rectal bleeding. And so when the rectum is the complaint or the rectum is the source where you can find information about the complaint, I still think it's a worthwhile test.
Absolutely. We have the same thing about, in the days of ultrasound, do you need to do a pelvic exam? There are many places where you don't, but there are places where you do. There are reasons to do these things. So this is, the notion of doing it to be complete is crazy. The notion of doing it because you're worried about the rectum is, you have to do.
But you will be impugned if you call a surgeon to come see an API and you haven't done a rectal.
Oh, I do
talk
that
about your character as being
Oh, no.
sort
I do
of
that all the
I do
time.
it all the time.
insufficient.
Yeah.
Yep.
I don't worry. They can impugn me if they
Well,
want.
they're going to ask for a CT anyway, you know.
Number 19.
19, safety and efficacy of antibiotics compared with appendectomy
This is
for
great.
treatment. This has obviously got to be a British paper. Because in Canada, the United States, and I think Australia, if you honestly thought it was appendicitis, how many people would just treat it with antibiotics and watch? Hands up. Well, you know, Jerry and I both spent a little time in England, and they're comfortable with this. They feel more comfortable with it. It is an infection. Antibiotics do work. And what they say is they can later go in electively and take care of this ruptured appendix. Now, if you look at the
Or
data-
unruptured appendix.
or unruptured appendix. Yeah, but the authors believe a trial of antibiotics should be considered for the initial treatment of adults, not children, but adults with appendicitis. I think this is a cultural divide that I don't know how we'd get over. Have you ever seen this done in the United States?
No, you know, I think there have been, they've cited 4 studies which have looked at this, and if you actually look at the results, it's not clear-cut at all. Many of the patients do fine, but some of the patients, if you go a year later, you know, what is it, 25%, 35% will eventually need to come back and have surgery.
Appendix.
And, you know, there are places in the world where they say that's acceptable. You know, you have to make your own judgment about
And there was a
that.
higher perf rate.
Yes, and it's
No
like,
question.
So, I think in the United States and Canada, North America, I think this would be very unusual for anybody to be doing this. And the amount of literature, there are 4 studies, but that's 600 patients. This is not enough to hang your hat on. So I'd be very cautious about actually implementing this in any way. On the other hand, I can imagine, supposing they did 2 large studies with 20,000 patients, and they randomized them to, you get antibiotics versus the other. People agreed to do that, and they found the same thing, which is that it often doesn't work, but it often does work. 2/3 of the time it does work. And 1/3 of the time, you're going to have to come back and have a surgery anyway. I could imagine this being a nice poster child for a concept that I think is very important called shared decision making. Why should I decide which one you do? How about I let you decide? Look, you know, if I do the surgery, we're going to get it out of the way. It's not a big surgery. It's done. You're done. Would you like that? On the other hand, I could offer you this other thing. And 1/3 of the time, you're going to have to come back and have an operation, and you might even have a slightly more complicated operation, but 2/3 of the time you'll avoid having your peritoneum invaded.
And every once
What
in a
would you
while,
like
you're
to
going to
do?
go on to have delayed complications like your SBO from the adhesions from the perf.
So I
and
think
you're
that's
gonna lose an
perfectly
ovary,
reasonable if we had
and-
better data to allow patients to decide which they want. And because I could understand a rational patient saying, I want the surgery, and I could understand another rational patient saying, you know what, let's try it and see if I get away with it.
And if you're going to do that shared decision-making, make sure your attorney's at the table, their attorney's at the table. I mean, this is complex in this country, I think.
At
When we
this
talk-
point, I think it's too early to do it.
I think it
but
is too.
But I wouldn't be surprised if we hear more about it later,
doing it.
and that it becomes a reasonable choice. Remember, diverticulitis is same thing on the other side, and we don't treat that with surgery.
Let's be fair about shared decision-making. When the two of you talk, who has all the cards in this deck? You do. You actually have a knowledge base. No matter how gentle you would like to bring them into the fold, you want to push them in a certain direction, and there's no question about
Well,
that.
that's a little different. I would like it that we should learn to actually say there are certain things where it really isn't up to me. It's really up to the patient. There are 2 choices. They each have pluses and minuses, and depending upon what the patient's values are. So let's take, for example, you have a migraine headache. You come into the ER, we treat your migraine headache, you're better. We now have 12 studies, small studies, of giving you steroids to go home with. And they all show the same thing, which is that a week later, you will decrease the chance of your returning with a second migraine by about 1 out of 10. So for every 10 patients you treat, 1 less will come back to the ER with a recurrent migraine. Now, should I be the one to decide, is 10%, is that good or is that not enough? Well, steroids have side effects. How about why should I decide for the patient whether they get steroids or not? What about I say to the patient, look, we can give this to you, it's going to have side effects. Some patients might say, you know what, I don't want to have another one of these terrible migraines. I'm willing to do it. I know that 9 out of 10 won't help me, but I'm willing to take the side effect from the steroids. I don't want to have another migraine. Another patient might say, you know what, I don't like steroids. They're miserable. I've had a course before. It makes me miserable. I'll try it without. If I have to come back, you'll treat me again. Why should I be the one to decide for them? Why should I have it that it matters to me? It should matter to them. There are many, many, many examples like that. I think we should get much better at this, where it's not I'm pushing A or B. That's not shared decision making. That's pretend shared decision making.
Yeah, Jerry, do you believe that for TPA too?
The truth is that as much as I think you have to be crazy to want to have TPA, I try really hard to make my presentation as neutral as possible. I really try hard to do that.
I'd really like to hear that.
Yeah, yeah.
I do. No,
If you're dumb enough to want this drug, good, I'll give it to you, damn it. You know?
No, what I actually say is, you know, you're going to be hearing from these guys, the stroke team, who think it's a miraculous drug and think it's really, really important. They're going to tell you all the reason why. I just want you to know that not everybody agrees, that there are people who think that it is unproven and it's actually not beneficial, it's actually harmful. That's what I say. I don't say you're an idiot to take it.